Uh-huh. So what do you think about that?
Really good, really good.
Okay.
Oh, thank you.
Oh wait. Yeah.
Okay. So, I hope that I know not everybody did, but I hope that when you answered this, you put it in numerical order by teeth.
Yes.
Indeed.
It's going to be a long night.
Sorry.
So,
Yeah, I'm sorry, miss.
so when you do it today on the OSCE, when you're doing notes about teeth surfaces and teeth numbers, put them in numerical order for me. It just helps my brain. Okay, so tooth number 1.
Missing.
2.
Lingual care.
Lingual pit caries amalgam. What kind of amalgam? Buccal classified. Number.
Quick question.
Yep.
Since I had to redo this, I was looking at this paper
Okay.
to see how you wanted the wording, just to be more specific. And for the amalgam, you don't classify them as like classes. Because I wanted to, I was doing it with Sunshine and she said, no, she doesn't word it like that.
Okay.
So for everything, you want us to list the class.
I would write down the class
Okay.
on it.
Restorations or
But
caries.
I'll take it. Yes, restoration or caries. I want the
So
class.
For anything, you just want to be the more specific.
Yeah.
Okay, I can do that.
Yes. Because if you're doing this on
That
paper,
was the only one though.
Okay.
Normally we do.
Okay.
For the amalgam, just like few classes.
you're going to be drawing today, not writing it out.
On example five.
No, you'll have one paper. It's the only paper. Okay, so, yeah, do it as detailed as you can because you're making a legal record. If you're in a place that is in the dark ages and has all the paper.
We need to bring our colored pencil.
I gotcha.
Thank you.
Sorry, just because I turned it in already and I tried to follow this as precisely as possible. For all the amalgams, I didn't put the classes, but for all the composites I did. Because for the composites, you have it, but not for the amalgams.
I'll work on being generous on it,
Yeah, I didn't put, because the first time we did it, I don't think anybody put classes.
right? So I won't worry about it. If you got the surface, I'll be happy. I'll give you credit for surface, okay? Okay, number 3.
Gold
Yeah.
crown.
Porcelain fused to metal.
No.
Porcelain fused to metal,
RCT.
Porcelain core.
full crown, post,
Porcelain core and root canal.
and root canal. Number 4.
Occlusal.
Occlusal.
Mesial occlusal.
Distal. Mesial occlusal.
MO,
MO.
the mesial surface,
That's not
Composite restoration.
composite. Number 5.
Is class 1 for number
It's
4?
ceramic crown.
Number 4 is class 2,
It's 2, because it involves.
because it's the mesial. Okay, so, number 5,
Ceramic crown and an implant.
ceramic crown and on an implant. Number
Ceramic.
6,
Distal
Distal
lingual.
lingual.
Distal lingual composite.
Composite.
Restoration.
I'll take distal or distal lingual.
Is that ceramic crown or no?
Ceramic crown, yes.
Implant.
On an
For
implant.
the distal lingual composite, would it also indicate that, looking at the incisal surface? Because
It doesn't include the incisal, it's just the distal.
so it's just a distal.
Yeah,
Okay.
For number 4?
for number 6.
Oh, sorry.
7,
Yeah, veneer.
8,
Fracture.
Distal incisal
Distal
angle.
fracture.
distal incisal fracture. Num- 7's a veneer. 9,
Mal.
How can you tell the difference between veneer and composite?
you can't in this. I mean, it's a veneer. You can't, sorry, you can't tell the difference between a composite or a ceramic veneer from this. But it's a veneer. How do you tell?
It's only on the facial.
It's only on the facial. 13.
Fixed.
13?
13.
Oh,
Fan.
13. Yeah.
Fixed partial.
Fixed partial denture.
14's
Okay.
missing.
14. Missing, pontic. What kind of pontic?
Oh,
PFM.
forgot that.
15. PFM.
Cervical fracture?
Cervical what? Caries, recurrent caries.
So that's,
But you circled it.
yeah, that's not how
Oh,
we
sorry.
have it.
Okay, okay.
Yeah, I credit for that one. Okay. Sorry, I should have filled it in. Yep, my bad. Okay. 16. 17.
Partially
erupted.
partially
Partially
erupted.
impacted, right? So mesial cusps are erupted. 18. Stainless steel crown. 19. Replaced with a partial, removable partial. 20.
Occlusal.
Distal occlusal caries. How did we detect it? Visually, clinically.
Yes.
21.
Mesial face.
Mesial caries.
Not overhang?
Mesial caries. How do we find it?
Because there's no respiration.
No x-ray.
Radiographically. Okay, so when you're looking at it
Oh, damn, I have to
clinically,
fit that.
you're going to look at the shape of it and draw it. When you're looking radiographically, you're going to do the triangle.
Like a triangle going inward?
Yes. So later, not yet. High T, we don't have to worry about that so much. Okay. What's 2 millimeter diastema. Missing, replaced with an RBD. Sorry, I'm just,
So if it's a PFM, it's gonna have the metal crossed in it, and if it's an RPD, it's just gonna be like floating.
Well, it's a circle. No, RPDs
how many lines?
3.
3 lines, and
The other one.
PFMs have 2.
Yep.
Thank you.
This is missing, replaced with an RPD. Removable partial denture.
29.
Just 29?
29.
Because it's 3 lines.
Because it's 3 lines.
Man.
2 lines is what? Yes.
We put that.
But I
Okay.
think I worded it different.
30.
Kind of-
MOD and
Overhang and
Distal
distal
overhang. 31. And oops, I'll give you credit for that.
Wait, what was 31?
3/4 ground crown.
Gold. Facial surface remaining with a lingual.
Yes.
Cervical fracture.
With a lingual caries, whoops.
Or
Impacted. Okay?
looks like defective margin.
I have a question for the
Uh-huh.
impacted teeth. How would you word the number 17?
You could say partial impaction.
Partial impaction. So what if we put it on the distal side? Like partial impaction, and it was distal.
So you could, so that the distal cusps were erupted because it's a horizontal impaction, you could say that, yeah.
Yeah. So like,
If I got partial impaction from you, I'd give you credit.
So the difference between a PFM and a partial gold crown is the gold crown will be outlined.
So see how this doesn't go down to the gingival margin?
Yes.
So that facial is not restored. Whereas this guy circled on the facial. So that's restored.
So that's it.
15. 15 is a PFM crown, abscess, and a facial, secondary decay, but whatever you wrote there, if you wrote something. 31, 3/4 gold crown, lingual secondary caries. If you said fracture, I'll take fracture.
Okay, so on the OSCE, are we going to be identifying from a chart like this, or
You're going to be drawing.
some and not all axia?
2.
Can you draw on that?
No, you can't. So it's one paper.
Paper and axia.
So it's, the question is in Exemplify, and then the paper is how you're going to respond.
How many questions are on this?
There are 21 stations. There are 3 break stations. 2 minutes per station. 20, yes.
So, can you just go over a little bit of the terminology? You said like, so that one where the carries is on the CJ, you call that secondary?
Yes, because it's at the margin of the crown.
Okay. What number is that?
Should be solid red, my bad.
And that makes it
So secondary caries is noted on the edge of the restoration where the caries is. So primary caries is what? What is primary caries?
the first time it's happened.
The first time it happened, right? We had a tooth that was intact and now it has decay. Secondary caries, we restored it and now it's got new decay around the restoration.
I know it's a question, but can we go over gold and PFM?
So gold is hash marked across the whole thing. Okay, and PFM has, wherever it is porcelain, it's going to be solid, or clear, not hash marked.
Oh, I know. So it's always facial or no?
So would you do a PFM if you were going to do a facial that was metal?
Maybe on the
Because what's the point of putting porcelain on the lingual only, right?
So like number 3 would be porcelain just on the facial?
Yes, and then a little bit on this occlusal,
We just say porcelain fused to metal.
porcelain fused to metal, PFM.
Normally a PFM, all surface is just inside, that's,
It
how would we
depends.
chart it? 'Cause
So it can be porcelain across the whole crown, covers everything, or it can be, part of it is porcelain and part of it is metal.
And it's the whole thing, PFM, all porcelain outside, how do we chart that? Just the occlusal would be,
So then I would just do a little hash mark around the edge of it. So why would you do a metal occlusal? Do you remember what I said? The opposing teeth. Porcelain's pretty abrasive. The metal is nicer to the teeth below, or opposing. Okay? It's gonna be okay.
do 5 more of these.
It's gonna be okay.
Everyone's like,
I just hope I'm looking good.
There will be some that you're gonna tell me on the final. There'll be a couple of questions about what does this mean. Okay. Study guide, that's my next thing. Okay. Like I say, just when you think you have all these things weeded out, I found this again. 1516 Gracie. What surface are we gonna use it on?
Mesials.
Mesial, no direct.
Okay.
Remember how we tried it in lab, it was ridiculous? So, mesial on the 1516. This was just grammatical. The 1314 is distals. That was grammatical. Okay, and then, forgot this was in here, so sorry. So I updated that to the current.
This is
So-
all, oh,
Go ahead, sorry.
no, sorry.
oh, nothing.
This is all.
Right, sorry, I'm so sorry about that.
We were like, wow.
What are you doing, Miss Lennon? I forgot it was in there. Sorry.
this is on the current study guide that's posted?
Then what I just reposted, oops, sorry guys,
On the announcement, okay.
into the future 2020. Okay, so slight, moderate, severe, stage 1, stage 2, stage 3, stage 4, holy cow, severe, complex, right? So, stage 3, class 2 or 3 visible furcations, greater than 33% bone loss. Stage 4, greater than 33% bone loss. Class 3 furcations, it's hard to tell class 4, but a class 4 would definitely be a 4.
Would we get any information on if there's missing teeth around?
Nope.
So we're just looking at the generalized.
You're going to look at a radiograph, you're going to tell me what's the class on a particular tooth. Okay?
Do we need to know healthy, moderate, or just stages?
Well, it's radiographic, so what does that tell you?
There's no, that means no, we're not gonna use bone loss.
There's, it's radiographic.
Where was the updated study guide posted at?
It was in an announcement.
In
For the lab.
It's in the lab.
Okay, I didn't see.
So, exemplified download,
Announcement.
download said, study guide, a little link.
So this highlight that I just did, that's all the,
And the screenshot, not the regular.
no, I don't remember.
Hi.
Me too. Don't have to worry about that. Okay, so those are the changes. Anything that's highlighted was a change. A couple of them were just grammatical. It's literally mesial for the 15, 16, and sorry, I put the wrong AAP, or left the wrong AAP in there.
On the braces, you have like mesial and distal question mark. What do you mean by that?
On the, which one?
Right there. Oh, it's
So
the
you could potentially use these on these surfaces. This is what they're designed for, but you could also use them that way.
So for the OSCE, do we just put mesial distal? Or?
You're going to tell me a particular instrument and a particular end
Okay.
on the instrumentation ones. How does this adapt?
Are we able to pick it up?
Yep.
The contradicting information I had a question about was the ultrasonic scalars and the tip colors.
Okay.
To clarify, my understanding, the blue tip is up to 12. So like,
Or up to 3.
oh, I didn't know that. So a medium, moderate to high?
Moderate to high.
Not just high. Because one area, I can't remember if it were the study guide, I'm pretty sure it was the PowerPoint. The PowerPoint says the blue one only goes, no, it was, the purple one was the high, the green was the lowest, and then blue was the medium, and it
So
didn't
blue,
match.
you can do high power.
Okay, so that's.
Right, the blue tip. The blue zone is the low, right?
Right.
It's the green tip. I didn't do that, sorry. So blue tip, you can do high power. And purple tip. Green tip, no. Okay, any more questions about that?
Are we so annoying?
No, you're not. You're just so freaked out. I know. Like,
Can we go over what to those sections?
the one?
There's a what to the example and there's a question.
No, you can do that. You're a capable human being.
Can you just go over what to expect? Like what are we doing when we walk into the room?
So it's going to be like the oral anatomy test. You'll have stations, and you'll walk through the stations. You'll have 2 minutes at each station. So there's going to be instruments out, or there's going to be an exemplify, chart these existing restorations, and the list of things for you to chart. How does this adapt? All that kind of stuff. So I'm going to need some typodons.
Oh, okay, I was going to say, you bring your type down?
So I'm going to have you guys drop off typodons for me, and we're going to set them up at stations. You've been doing this 3 quarters, you can do it. I promise you can. So it's the same idea. Instrument, some of it's instrument ID, that the numbers are covered. You're going to tell me what it is and where it's used.
And our laptops have to be charged, right? 'Cause we're carrying
Yes,
them.
please charge up. Don't come decharged, because that's crazy.
Is the where it's written or is it typed out and then?
It's on and typed on. Here's the instrument. Here's the tooth surface. Tell me which end. And they're marked A, B, C, D, E, whatever.
It says on the old state guide that you have to choose the correct files and correct and to scale.
Yep.
So we're testing on the file.
Yep. Yes, some of it's multiple choice, a lot of it though is fill in the blank.
And how are all 40 of us going in? 42?
Yes, so that's what I was saying. So, sorry, forget that I said 2 groups. We're doing 1 group. Just show up at 1.
But there's 20 stations?
There's 21 stations.
So how is it that we're gonna do?
There's 2 duplicate tests. Last year, I set up a duplicate test, and I forgot to write down, don't do 2 groups, do 1. Let's get done.
Did somebody already ask if we're getting tested on like ID, the instrument?
Yes, there's instrument ID. What instrument is this? Where are you going to use it? Okay? Kind of okay? All right. Well, let's quick and do our lecture stuff here. All right. Let me look at my list. Did I talk about everything? Exhale, new oxygen. CRs. Yep, got it. Okay. Lecture. Okay. So, margination of restorations. So this is not something you're just going to go out and your next clinic patient go, oh, let me scale off the edges of your restorations. This is going to be a thoughtful thing with some instructor help if you're doing this. So, trying to provide you with the basic knowledge to be able to think about, is this an appropriate thing to do, and then how would you go about doing that. So, rationale. Any excess restorative material left at the margin of a poorly contoured restoration, totally a giant plaque trap. Definitely going to cause problems for the patient with their ability to keep things clean, and it's going to potentially cause decay and periodontal disease. So anytime we have extra material hanging out the side of the tooth that extends beyond that margin of the prep, what we call the prep, is going to be a problem. And it can happen with any kind of dental restoration. So we fairly often see overhangs on amalgams. They're pretty easy to see on the radiographs, but it can be any kind of cast crown, machined crown. If you don't get a good image of the tooth or good impression of the tooth, you're not going to be able to replicate the normal anatomy that will adapt to that particular tooth that you're restoring. So, when we think about these things, we think about a couple of things. Either it's an apical extension past the prep, or that it is just overall bulk. It's just extra material in there that is sticking out the side of the tooth. So, this is a bit of glory here, right? So, even if you're Adventist, vegan, you might want to go work at McDonald's and flip burgers for a while instead of working in a place where all the patients look like this, right? If this is the work being produced, I don't want my name on any of those charts. Just saying. So, tell me about number 2. Mesial overhang, right? So, apical extension, right, and overall bulk. So, this guy is probably because they didn't wedge the band around the tooth very well, and so they're packing the amalgam in, and it's leaking out the bottom of the prep and into this tissue here. You like this nice crown?
Yeah.
So this, my first boss, my orthodontist who did my ortho, poor guy, yes, I look like this now, but he tried hard. He would say, because he's an old farm boy, he'd say that fits like a bucket on a fence post or socks on a rooster. That was his other favorite thing. So this one's not great looking. It's more subtle. Who knows what's happening there? You know, none of these are very lovely. So, what do you know? Like so many other things in dentistry, we categorize these as 1, 2, and 3. And 1 is like, okay, you could probably take that off because it's a little extra something. 3 is, forget it, just take that thing out. 2 is in the middle. You might need to actually have really, like even a separate appointment to fix the margin. You may need to anesthetize the patient to get good access, and you're going to have to spend some time really deliberately working on it. So what are the kinds of overhangs we're going to be taking off? Mostly amalgam. In what class? Or what type?
Mostly type 1.
Type 1. And if it's anything significant, we're not going to tackle that. We're going to be able to just remove the really light guys. So, defects that cause marginal discrepancies. What do you know? Over-contoured is what we're talking about when we're tucking in overhang. But they can be under-contoured too. And then also we can have defects of the margins because of secondary caries. And you got to know the difference between those because we treat them differently. So, can have overhangs on anything. If we stick it in there, it could have an overhang. So these crown margins aren't beautiful. They've caused some recession of this gingiva, and now the porcelain fused to metal margins are showing pretty, right? So we want to make sure we make really good margins to be able to be kind to the tissue and keep the tissue from retreating away from that restoration. So what do you know? Where do they happen? Mostly the places where we have trouble scaling, right? Because they're inaccessible. So interproximal, subgingival, open bifurcations, and those developmental depressions, just exactly the same places that we have trouble as hygienist accessing. It's going to be tough for the dentist to also restore. So when you're doing an amalgam, for instance, or a composite, you're going to have some sort of band around the tooth. You're going to have these little wedges because we want to fill up the embrasure to smush the wedge against the tooth surface. And this band is what is going to contain the filling material, the restoration material, to be able to keep it adapted to the surface of the tooth with fairly normal anatomy. So, if you don't get that indeed there should be, what do you know, embrasure space, so that the papilla has a place to live, or you forgot that, then that's going to be a problem. If you don't do a good job preparing the tooth, and there's no room for the restorative material, that's a problem. If you don't use the wedges, as I say, to snug this guy up, that's a problem. And amalgam, when it gets exposed to moisture, can actually expand and actually kind of push out of the tooth. Finishing errors. So, if the dentist is one that just is driven by the dollar and they just have to make their $1,000 an hour, and it's like throw the amalgam in, tap it in, and move on because they don't have time to spend on that crazy finishing stuff, then that's a problem. So they may literally have to make $1,000 an hour. Let me think. The last time I had a practice management training session was probably 15 years ago, and they said, $6.50 an hour to keep the doors open. You got to be making $6.50 an hour, right? So if somebody is really driven by speed versus doing a great job, that can be a problem. Improper adaptation of the finishing instruments. Some of them are very similar to scalers, and so if you are not adapting those correctly, you can, if you don't adapt scalers correctly, you leave calculus. If you don't adapt the finishing instruments correctly, you can leave excess material. And then, oh my gosh, wouldn't you love to be doing the composites on this person and try to finish them? Narrow embrasures, malpose teeth, any other anatomical irregularities. So here's the thing. You can also have problems with nervous or anxious patients. Has anybody had a super nervous patient?
Yes.
And like they won't hold still, they're talking or they're wiggling, and if it's a family member, dear God, right? I'm just going to take this Explorer and just like thrust it through your earlobe to pin you to the chair. Yeah. Just a little. Poor access, bleeding, if the tissue's not healthy, but you have to get a restoration in there. A strong gag reflex, or you didn't give yourself enough time to really get the job done. Right? So just like if you said, oh, we're doing this 4 quads of replaning, and oh, we'll do this in an hour. Same idea if you're doing some complex restorations and you're not giving yourself enough time. That's a big issue. So, poor inadequate preparation of the tooth, poor gingival health, so bleeding and difficulty in retraction when you're talking about a cast restoration or now a machined restoration where they have to do the laser imaging of the tooth. You've got to have tissue that will stay away from your prep margin and allow you to access that whole margin area, subgingival. And so if their tissue is floppy, sloppy, bleeding, that's a big problem. Maybe you had poor isolation during the impression, or the impression got distorted. So when you're in dental materials this summer, if you are trying to get yourself a little time between when you took your partner's impression and when you're pouring it up, and you wrapped it in paper towels and it was either too wet or you used hot water, it'll really warp the impression. So then the restoration's not going to work. And then the dimensional instability of the materials. So the nice thing about doing the machined crowns is we take the laser information, imaging information from the tooth, and today put it into a machine. As long as you have a good image information, then you don't have distortion of the materials. It just machines it to the precise dimensions. If you're talking about an impression, the impression material itself changes dimension. We have, we work on having really, really good, stable, accurate impression materials, but there's always a little bit of distortion. When you pour up the stone in there, the stone expands, contracts. When you then take that dye that you're going to make your wax up on, the wax expands, contracts. And then when you cast it, the metal expands, contracts. And if you put porcelain on it, you may do multiple firings of it to attach the porcelain to the metal for the crown, and it expands and contracts every time. So there's always some distortion built into the system. But if you do something, for instance, to the impression that really distorts it, that's going to be a big problem. Over-contoured or overhanging crowns, bridges, porcelain veneers, those things we can't fix as hygienists. And the dentist is not typically going to be able to fix them. If you have full gold crowns that have an overhang, but the margin is sealed, then sometimes you can go in there and polish them off and make it work. But mostly, you've just got to remake these guys. So, small to medium composite or amalgam restorations tend to be our go-to, that we can actually make that margin better and be able to remove the overhang on it. Now, here's the thing. I promise you, you've been out 20 years, you're going to take an FMX that you took an FMX 5 years ago, you took bite wings 2 years ago on this patient, you take your new FMX and you'll go into your boss at the end of the appointment and you'll say, okay, so the piece of calculus on the FMX on the mesial 13 is now gone. Sorry. Or, some molar that's malposed or something. For me, it was like mesial of 18, malposed, mesial version. Like, oh yeah, that's probably been there multiple years that I've been scaling their teeth. Awesome. Right? Doesn't mean I completely suck as a hygienist. I'm a human being. Right? So, again, if you have the crazy picture in the beginning and all the patients look like that, bye-bye, I'm working someplace else. One boo-boo does not make somebody a horrible clinician. Still human beings, right? So, you got to think about, is this the patient who maybe has mental health issues and can't sit still in the chair, and, it's very challenging, and they did the best they could, and, people need some grace sometimes. So, you're going to think about that when you look at the x-rays and you talk to the patient. Okay? So, the value of this, we're going to try to facilitate proper home care, prevent food and plaque retention, prevent mechanical irritation of the tissue. If you've got a big old thing sticking out like a thorn in the papilla, what do you know? It's not happy about that. And we want to reproduce natural functional anatomy, preventing bone loss and secondary caries. So, here's the thing. If you're going to be instrumenting these restorations, you have got to remember oral anatomy. Okay? Because we're trying to reproduce the normal anatomy, so you have to know what the normal anatomy is. So, contact areas. Remember, anterior teeth are near the incisal, posterior teeth are in the middle, a third of the tooth. As you go anterior to posterior, they tend to be more facial, on the facial lingual, and we've got to have embrasures that are appropriate size and location. Remember that contacts are not a little tiny point, but they're also not the whole surfaces of the tooth, proximal surfaces flat against each other. So it's a contact area. Anteriors are skinnier, posteriors are larger. You're going to think about that for probing and also if you're instrumenting a restoration. Right? You don't want to remove a whole bunch of material and leave a little tiny pinpoint contact. And you got to think about where those embrasures are on the occlusal and the lingual and the facial as well. So think about the embrasures from all dimensions. Okay, this is the most important part of the lecture. If you don't take anything else away from this, the next few slides, take this away. So, pencil out if you need it, make some notes on your slides if you are doing that, whatever it is. Okay, subgingival contours. How can we tell where the CEJ is when you're trying to figure out, for instance, cal? What's it going to feel like when you're exploring? Right, so fairly smooth for most people. A little depression where? Right at the CEJ, cemento enamel junction, right? And as you come out of the tooth, out of the pocket, it's going to what? It's going to catch a little. So it might even click. I know you have the answers already, but think about it. Okay, so what's my next one? So then, here's our sheet of calculus. So, 5 miles of bad road. That whole surface is going to be a little rough. So it doesn't necessarily click, but it'll have dimension. Meaning, if I go in here with my Explorer, I'll be able to get below it, above it. At the depth of the pocket, I'll be able to feel it, that it's some tooth surface under there. And then I will come across that surface and then drop off of it. So it's going to be a little up, over, and down. It's like a very flat speed bump that's very rough. All right, a big ledge of subgingival calculus. What's that going to feel like? Which way?
Both ways?
Both ways. Right? So, and it's going to be an outie. You know me in the scientific language. Yes, I mean belly buttons. Okay, so it's an outie. You're going to click over it. This will be the speed bump. Or maybe just like a wall of calculus, if it's big enough. Big old ridge. Okay, what's this? It's an innie. So what is that? It's caries. Okay, so underneath the restoration or on the tooth surface, what's that going to feel like? You're going to fall into it. Okay, can you scale this off? Right, so I promise you'll try to scale one off at some point. That'll happen. But think about it as you're coming along there. Is it within our scope of practice as hygienists to remove carious tissue? No. Right? So stop. Stop. Do not fire up your ultrasonic and think, I'm going to smooth the edges of this out. It is not going to happen, and you'll destroy the tooth. Right? So if you're falling into it, that is a problem. Not our problem. That's the dentist's problem.
Will that be painful if we like stick
It could
fluoride?
potentially be very painful. Let me take this caries lesion and shove something in there and scale it, right? So, this guy, we're gonna work until that outie is gone. As it smooths off, what's gonna happen? How's it gonna change in feeling?
Maybe smaller.
Smaller and smaller. How about if we don't get it all off? Burnished. What's that feel like? It's going to be pretty smooth. You're going to have to actually work harder to feel it. It'll still have a little bit of dimension often, or it may just feel like a little bit tacky, we've talked about, where it just drags the Explorer a little bit more. Okay, thinking about these guys. Which way is this going to click? On the way out, right? And then as you go in, you're going to drop off of the edge of it. Okay, and then how about this guy? You're going to fall in. And then this guy? Yeah, it's going to feel like calculus. If the margin underneath is open, then it could turn into this feeling, where you drop into it. Hopefully they didn't, hopefully they actually seated the crown all the way. It doesn't always happen. Or they didn't get a good impression, so the margin was cast short. But if there's a big old piece of calculus, it's going to feel exactly like, big old piece of cement, it's going to feel exactly like calculus. What do you know will be exactly where the margin of the crown is. Okay, so, over contoured, this guy's going to click both ways. Flash may not click, but you'll be able to see on the radiographs, or you'll be able to feel some extra dimension to it. An open margin is going to feel like caries, where you'll drop into it both ways. And then an under contoured one, you're going to fall off of it as you're coming out of the pocket, and you'll run into it as you're going in. Okay, so you got an outie dimension, but no click, innie, and click on the way in. Make sense? All right, so really think now, as you're exploring subgingivally, you can't see, you will first have consulted your superpower, your radiographs. You're going to correlate the radiographic findings with what you're seeing clinically and feeling clinically. Always, always, always. Okay. These are not implants. These are actual teeth. This is a patient that we saw in our perio office who flossed shoe shine for years. So here's the gingival margin. Here's these giant divots, ditches in the surface of the tooth. And then you have root surface up here.
Are you saying those are not implants?
Those are not implants. Those are natural teeth. So imagine trying to get this clean and not kill their tissue and not leave any plaque. I managed to pretty much do that a few times. Oh my gosh. So this marginal discrepancy, or this problem on the surface of the tooth, you know, when you first went in there, it was like, oh dear God. But we always looked at x-rays first, and we had copious notes on this patient. I've never seen a patient like this before or since. But this is the deal with making sure that your patient can floss correctly, because they don't usually do, obviously, this amount of damage, but it can be done. The other thing is proxy brushes. I've seen whittled away root surfaces on lower anterior with a proxy brush.
Would you say especially it looks like either? Yes.
Frightening? Yes.
Does that tooth have to be pulled? 'Cause
Nope.
It looks like it only has the pulp.
So, good news, you can't really see because these images are so bad, but the pulp chamber has retreated away. because it happened over time. Right? So be careful what you teach them. Never teach them something that could cause trauma. Pretty much never teach them anything without making them demonstrate to you. If they're using a proxy brush, every single time their fanny hits my chair, I want to see how they're using that proxy brush to make sure they're not doing something cray-cray. Okay, so how are you going to tell? Gosh, the boss did a couple of fillings 2 weeks ago, and ever since then the patient has shredding floss, or they came from someplace else, and gosh, there's this place that shreds my floss every time. It doesn't taste good there. It doesn't smell good to me. I always, if I have ribs, I always have to floss that spot. The papilla looks bad. The place is sore, roughness, bleeding, any of those things. Radiographic. So remember me saying two-dimensional image, right? So we're going to see mesials and distals, and that's about it. Till we are all on tomography. It's going to be mesials and distals. So you got to have all your current restorations, appropriate vertical and horizontal angulation, so your contacts are as open as possible, good quality and contrast, and you should have good angulation to evaluate the bone height around all the teeth. That's just a given for all radiographs, but you need this if you're going to be doing overhang detection and removal. They've got to be current. So, horizontal angulation, yes, I can see in between these teeth, and I can tell, yes, there's an overhang here. Overlap like this, no idea, right? I'm not going to get into something that I can't evaluate correctly. So, visual, you're doing gingival assessment. Gosh, that tissue looks horrible. Looks like hamburger in there. Why? Well, there's no calculus, but there's this big old filling in here. You use your direct and indirect vision using air to retract that tissue. So just like really heavy calculus, a really bad overhang is going to make it puffy, sloppy, yucky. You'll be able to blow air and it will go away from the tooth. Probing or scaling, if you run into or you bump over the bulk of an overhang. So has everybody run into some calculus already? Not everybody has had enough calculus skill. When you're like, oh, probing, versus this, like, okay, something's down there. After you're done polishing your flossing, and I feel like, oh, I did a good job taking the calculus off, but the floss is shredding, you're going to go back. It's likely an overhang, might be calculus, but you're going to go back and check. So if it looks like this, something's happening. Find out what. Figure out how to fix it.
So if you have a patient that isn't due for radiographs as far as the length of time in between, but they just had some restorative crowns or such put on, is that automatically you need x-rays so I can see what?
So it's not automatic that they need new x-rays, but if they're having an issue around something new, I might take one film, check with the dentist, might take one film to evaluate it. Okay, so subgingival overhang, supra, obviously this guy's easier to take off, harder to restore in some ways because it's tough to be able to wedge those guys. Going into the opening of a furcation, I've seen these before. Mostly I see the crown is not fitting the contour of the furcation, so you have this big ledge that overhangs the furcation, so that makes it better, right? Oh, now this big elbow is sticking out. I can't get under it to get into the furcation. Good news with these guys is you can, if it's a buccal or lingual, they're relatively easy to recontour. If it was this much, I would be saying to the boss, yeah, have fun with that. But, oh my gosh, you got to get that thing out of there so you can get into the furcation opening. Best way, though, is still tactile. You're going to explore all of the surfaces around all the restorations to see, are they intact? What's the contour look like? So you're always evaluating not only do they have calculus, but you're also wondering how are all these restorations doing? If there is root caries underneath the restoration, secondary caries, guess who's going to find it? It will not be your boss. It will be, where are they looking on radiographs? On the crowns of the teeth at the contacts. Right? We're on the root surfaces, scaling in there. We'll find them. So you're going to carefully evaluate them, and you're going to talk with your dentist if you find something that is an issue, and they will evaluate it, determine the etiology, and see if you need additional treatment. But you're checking everything all the time. So secondary caries at the margin or caries on another surface, mesial overhang, distal caries. We're not going to fix that by trying to smooth the margin, right? They have secondary caries. We're done. That guy's got to come out, get replaced. But if, for instance, you have an overhang on the mesial that you could restore to some good function by doing overhang removal, but they have caries on the distal of the tooth, so you need a new MOD, then skip doing the overhang removal. Why would you do two procedures to the patient? Make sense? So if there's another reason to redo the restoration, we're not going to worry about the overhang right now. If there's a marginal deficiency, wow, my floss flies in and out of this, and I pack food in there all the time. You know, like half the ear of corn comes out after yeah. You can't obviously fix that because it's too little material. Don't take any more off. Restoration's already scheduled for replacement. Gosh, it's just so bad. This filling is a mess, and we just need to do a crown. Obviously not going to worry about it. And if it's a ginormous thing that looked like somebody threw it in from across the room and said bite down and move on, then that just needs to be fixed by removing it and starting over. Right? So we're not going to take on things that are not fixable. So this thing's pretty giant. It's subgingival. That just needs to come out and be fixed by putting a new one in. Can't fix that because it's a cast restoration. Can't fix that because it's a cast restoration. This guy I could probably fix. This one might have some secondary caries. That's probably too big. That's probably too big. Secondary caries, huge, right? So you're going to really evaluate what is in here that I could do something about. You know, maybe number 4. And the rest of it is not my problem. It's too big.
So secondary you cannot control.
So secondary caries, can you adjust that off? Right? Just need to get in here. And probably root canal therapy and a crown, right? I'm not fixing that with anything I got in my toolbox.
So we can do composites and amalgams.
Pretty much composites and amalgams are what you're going to do. So what you're going to do then is you'll have a little experience with overhangs in dental materials. We'll make you do an overhang when you do your restorations, and you'll have some practice taking it off. Okay, so finishing and polishing. Excess flash, rough margins, class 1 or class 2 overhangs, little surface imperfections. Sometimes we just polish up amalgams or composites that have little problems with finishing. Premature occlusal contacts, the filling's too high. Right? You touch down and only that one tooth touches now. That we could polish off. Minor defects or anatomy recontouring. We want to repair things that have slight voids in the material, or they are a little open margin, slight fracture in the marginal ridge. We can sometimes repair those. But replacement. Class 3 overhangs, more than one half of the embrasure space is filled up by a ginormous overhang. That whole restoration just needs to go. Too much. An open margin, recurrent caries, or an open contact or broken marginal ridge, we want to replace those guys. Okay, so basic idea, pick your battles, only things you can fix. Don't get your name on the chart on something that's crazy, right? And do crazy things with it. We're just going to take the little things that we can, minor defects, and see if we can fix them up. So how are we going to do this clinically? Well, what do you know? First thing is review the chart. Does this patient have a necessary pre-med, an allergy, something like that? a medication that might cause bleeding, anything that would contraindicate the procedure or that you need to address before you do it. You're going to look at their charting, especially the recently placed restoration and the initial existing restoration charting. You're going to see, is this our restoration or did they come in with it? Okay, so if they came in with this restoration and it's problematic, most of the time we're going to say, how about if we just start from scratch, because we don't want to take on somebody else's problem unless it's something easily fixable. Because we may not know what's going on underneath that restoration. But if it's something that we did and it's recent and you work for somebody with awesome ethical standards and they're like, yeah, that just needs a little more work, we're going to fix that up for you. There's your ticket right there. So that's the thing now is, wow, that's just a terrible feeling. Who the heck did that? Well, your boss did last week. Right? Need a little salt for that thigh that you, yeah. So, always check the chart before you open your mouth. Okay? Know what you're talking about. Get your armamentarium together. Take care of the patient's comfort level. So if you're going to be fishing around underneath somebody's papilla, we're going to want them to still speak to us when we're done. We're going to get them numb, right? Anesthetic, nitrous, whatever the patient needs. It may be a tiny little spot that you just need to say, hey, I'm going to just scale a little extra on this little area. That's fine too, as long as that's appropriate. You have to have really sharp instruments that nothing can be really skinny. You've got to have a really good stable fulcrum, good grasp. You're going to use your whole arm to activate these strokes. Moderate pressure, you're not going to go Hulk on it. You're going to use moderate pressure. Really controlled overlapping strokes. And you're going to go just to the 51%. You're not going to reach way over. And you've got to try to keep the finishing, whatever you use for finishing, half on the tooth and half on the restorative material, because you don't want to gouge this thing out. What you choose depends on what works for your hands. So given a particular restorative material and the job you have to do, different things will work best for you. And tissue condition, all those things that would affect the accessibility and how hard this job's going to be. That's going to help you decide what to do. So, first you're going to start by just getting the big, just like scaling, big old hunk of chunkas off there. So heavier gross removal, start on the apical portion of it and work towards the contact. And you're going to keep the instrument, again, on both the tooth and the restoration. And you've got to just be intimately familiar with the anatomy you're trying to create or recreate, and make sure that you are adapting as you need around the tooth and around that restoration so that you're indeed actually producing that anatomy. Keep checking really often. Right? A little tiny overhang that turns into a deficiency because you scaled it out, that's not going to keep you there for the next 25 years at that job. So, mirror, probe, explorer, high volume suction. If these are bad enough, you sometimes have to do a rubber dam. If it's that bad, I would say then the dentist needs to be doing this instead. But sometimes they'll do a rubber dam so that you can increase the visibility, control the bleeding of saliva, really visualize what's going on. So, these guys are not used as much anymore, but this is an amalgam or a gold knife, and it's like a giant sickle. And so these guys are really strong. You would sharpen them similar to a sickle, but the gold knives actually are triangular cross section, but the pointy part is at the top. So it's kind of like a scalpel. So picture this straight thing under the papilla, subgingival. Okay, so you have to be really cautious. The patient would probably need to be numb. And you have to be super, super knowledgeable and careful. So half of it on the tooth, half of it on the restorative material, not toe in. right? Because we don't want to gouge this out. We're going to try to be really carefully adapted to be able to do that. So this is not used typically by hygienists. Typically we're going to use our scaling instruments instead. Files. So we talked about files. These work really nicely, those horizontal strokes, to be able to take a small overhang off at the gingival margin, the margin right near the gingiva on a class 2 amalgam. Perfect. Works really well. But again, you're not just going to file away on the amalgam itself, go crazy on that, and then gouge it out. You've got to stay half on the tooth, half on the amalgam, and just work on keeping those little blades in a really good angulation with what you want as far as the contour of the amalgam, so that you have the nice taper to it, not a big across the lower part of it. Well, it wasn't overhang, and now it's a cliff edge. Sickle scalers, same idea, really flat against the tooth. You're going to mostly work just right at the little margin. You don't want to roll up too far on the tip, because you can gouge the heck out of the restoration, and you're just going to shave off little areas of the restoration. Hartzell 1011 are really good for slight to moderate overhangs. And you already have them, again, like the sickle in your hand, so pretty easy to do, especially the little tiny guys. You just have to, again, be careful that you're taking the amalgam off, but you're staying true to the anatomy, and that you're not gouging out that edge. And then here's a thing where you might want to actually use chisels, which would be more of the actual restorative instruments, where you would go in there and do that horizontal push stroke, and they work nicely supragingival and in areas with receded papilla. Right, so you're going to think about, just like if you were trying to remove calculus with them, it's an accessibility issue. But they do work really nicely for getting larger supragingival, interproximal guys and anterior teeth. Ultrasonic. So, here's the thing. They're pretty rapid. The water spray is really nice, keeps flushing stuff out of there. They're better on large overhangs, especially if you're just going to try to get, it's more of a gross scale of calculus. Like if you had the wall of calculus and the patient can't reach their teeth, then you could do the gross scale where you just get the big hunk of chunkas off so they can at least get the bristles to touch the gingiva. Or gosh, I could actually get the floss to go in between the teeth, or the prox brush, whatever it is. So if somebody comes in with root planing needs, lots of calculus, but also lots of problems with restorations, I have in the past knocked off big old chunks of amalgam that, like say, looked like they were thrown in from across the room, and just so that the patient had enough access to the papilla that they could do anything in there to help make things better. If they're that large, generally I would not be considering, these would be things that would need replacement, right? But if you did have something that was more moderate versus heavy, you may then finish with hand instruments. But you'd have to be really cautious not to gouge those guys up. The ones I've done with my ultrasonic are like, I don't care, this thing's coming out. In fact, it may fall out when I take the overhang out, because it might be the only thing holding it in. Right, so if you are just trying to do this to actually preserve the restoration you're working on, you would have to work far more delicately, and you're going to be really cautious to make sure that you're not taking off big pieces that would actually then change the anatomy to something you don't want. No slimline tips, not a regular tip on low power. You're going to have to be high power. Slow, continuous movement, gentle, really light pressure, right? Because you don't want to stop it from vibrating. You're going to use the lowest effective power setting. You've got to keep it in motion at all times. Patient's probably going to have to be numb. They may tell you the tooth feels hot. Then you need more water and probably also be numb. But you've got to finish with hand instruments and abrasives to get it really smooth. There are some tips that are actually made for overhang removal. This company, Parkell, does this particular tip. This is a piezoelectric. So it's not the elliptical, it's the vibrates back and forth, so a little more controlled. It's got an abrasive and it will really power through the big old hunks. So this is all great on this extracted tooth, but one of the reasons this tooth is extracted is when we're done, yes, we got rid of the overhang, but what does that margin look like in figure 6 now? What about the margin of that restoration? Right, there's secondary caries in there. So, could you do a nice job on an actual, salvageable restoration with this? Yes. But don't think that's what it should look like in the end. All right. Dense ply, which makes your cavitrons, also has an overhang removal tip. Once you're done with that, ultrasonic and hand instrumentation, then we're going to use some polishing discs usually. So these guys go on this little mandrel, they go onto a slow speed handpiece, and then you're going to be able to, this is a little sandpaper on a disc, and you're going to work on smoothing that guy out. You're going to try to stay a little bit on the enamel, but mostly on the amalgam or composite, whichever that you're finishing. And you're going to take it easy with these guys. Don't go too fast. You can heat up the tooth. And this is more of the, I got the big bulk off. Now I'm just trying to make it polished and shiny and smooth so that plaque will not stick here. Sometimes finishing burrs or finishing stones are used for overhang removal. If you need a burr, but to do them, then lots of times it's just better to replace them, unless it's more of a, the surface isn't great and I'm just polishing it up. Finishing strips, these are little mylar strips that have abrasives. So like the diamond files that you might use for your fingernails, they're like that, only on a flexible strip. You basically do a little, there's a little clear spot that doesn't have any abrasive. You floss them down in there, and then you do a little shoe shine against the tooth. The strip of the mylar is fairly stiff, and oh my gosh, you can cut through papilla like crazy with those things. So you're going to be really cautious with them. We do sometimes see in the past people want to take finishing strips to the board exam. I'll just smooth off these surfaces. So you're going to deliberately burnish calculus you left. Also, gross trauma is a reason to fail. So if you zip that strip out and you slice their lip, that would be your, fail. And we probably won't let you test again. Okay, when you're done finishing strips, if you're using them, then dental tape and pumice, polishing it up with just regular prophy paste or a restorative, appropriate kind of polish. Then you're going to rinse and rinse and rinse. Get all those unattached particles of restorative material. You don't necessarily want to be the person that makes the amalgam tattoo, right? And you're going to use a lot of air and good light and direct and indirect vision and explore. And make sure you've really got it. Good contour and very smooth. So these are the abrasive strips. Small excesses, you could do a very tiny excess. You could kind of file off. But like I say, sharp edges can be really tough on the tissue. So this is the little floss it in there, little shoe shine guy. Dental tape. You can polish and leave the polish on the tooth and then use the tape to rub against there and get it a little bit smoother. And then rinse and rinse and rinse. Post-op. You can tell the patient if you had to go in there and really deliberately do this separate procedure, they're probably going to be kind of sore, right? So warm salt water rinse, maybe chlorhexidine. The warm salt water is usually more soothing. They may need a little ibuprofen, Tylenol, other pain medication. They've got to keep it clean. And to give them the written post-op instructions, the little for your comfort sheet would be appropriate for that. Make sure they've got a phone number to talk to you. And then you've got to document them. Teeth numbers, surfaces treated, type of restoration, what you used on there. Did you use local, was there bleeding or not that you had to deal with, post-op instructions, pain meds, prescriptions. Sign and date that guy. So, questions on the amalgam part? Are you still awake? Kinda. Nobody's head desk yet. So okay. Composite. So composite is tricky because they're very hard. They can actually fracture if you work on them too much. So it's much more difficult. Probably your boss will be doing this kind of stuff. If there is an overhang, again, that's interfering with the patient's ability to clean, I have done overhang removal on these guys knowing that they were going to have the restoration replaced. So I've gone at them with sickles to try to get rid of the overhang that was making the patient crazy. So, finishing knives, scalpel. Am I going to do a scalpel in their mouth? No, that's not my thing. Y'all who have practiced with that, all you dentists that have practiced that, go for it. I will not be doing that. But sickle will work for me. Finishing the margin with burrs, diamonds, or abrasive discs works. We were actually, when I was in hygiene school, you could do all of the registered dental assistant duties when you were in RDH. That's not the case for you guys anymore. It's a separate deal. We're working on getting it back eventually. Evaluate the composite after you've done all that polishing, correct errors, maybe have the restoration replaced. Okay, so there's a little dimensions of dental hygiene thing. This is my kid. There's Sandy. Sandy Koufax unit, because Dodger fans. This is her with her, she does sprint length triathlons. So, my kid, but very different in some ways. So this is them. This is, I think, the week before, like, oh, we're doing a swim around the dock, because, you know, they're on the ocean in Santa Cruz, and, oh, yeah, there are sharks out there. There's just a big great white shark. So, okay, thanks for letting me know that 2 days before I go in the water. Okay. This is Sandy has her little duck raincoat. So she has finally learned to swim. I tried to get her to learn to swim. Basically, I finally just literally threw her in the deep end. She learned to swim. Hated swim lessons. Why didn't you teach me? I tried. He did not want to follow the rules. So, and here's my son. Single. Just say, call me later. After graduation. His beard is much longer. His friends say it should have its own Facebook page.
Do they live here in California?
So my son still lives in my house. We're working on it. It's getting better. And this is the one that's 3 minutes around the corner in Santa Cruz. So, Eagle Scout, right? Many positives, and he's getting his life together. And I'm happy for him to move out sometime soon. And this is my dad a couple of years ago. And this is my daughter's boyfriend. And Sandy is like me. It's over 70 degrees and the sun is out, so I'm out. I'm done. Right. So this is his favorite place in Cambria, overlooking the ocean. I've actually seen whales spouting off of here. Still looking for my first sea otter. Oh, we saw sea otters. Why do I never see the sea otters? And so he likes to walk out there. This is when he was still using the trek poles. He's on the walker now, so this doesn't happen a whole lot anymore. But, you know, still living at his house, so it's good. Questions?
How old's your dad?
92. 92 now. Right? He started smoking when he was 12. He smoked till he was 50. Right? Do I want these genetics? Yes. This is my brother says, the man is a cockroach. You go in there and he's like, he's the child of the Depression, right? There's a little mold on it. Just scrape that off. It'll be fine. You look at the date. Dad, the peanut butter expired 2 years ago. It's fine. So his microbiome, we should all probably get a transplant from. Still does the gym 6 days a week. What he does at the gym has gotten less, but still gym 6 days a week. Okay. See you at 1 o'clock.
Can we make that 1:30?
All of you, 1 o'clock. Do you not want to go home? I want to go home. at 1, everybody, we'll have you split up in 2 groups. We'll get everybody done at once.
Tell me about.
Sorry, I cannot hear. Go over what?
Selena and the typodons. Miss Selena doesn't want to listen when I say the typodons. That's not really good, right?
Right.